Assalamu alaikum everyone. It has been a week we are discussing about this neurological case in various WhatsApp groups and community. So the case is about the extent to which a patient having the neurological findings of disc bulge at L4 L5 levels is related to the clinical presentation of the foot drop. So before going into the case and discussion, we should know the background of the anatomy, because for making any of the diagnosis or any of the neurological, pathological, or the physical diagnosis, you should have the strong background of anatomy, or you should have the grip of anatomy. Basically a neurological case which is dealing with the disc bulge at L4 L5. Posterior supply are shown in the pictures. The anterior view, which describes basically the lumbosacral plexus and its branches, starting from the lateral cutaneous nerves of the thighs, operator nerves, then lumbosacral trunk. Basically, all the branches of the lower limb starts from the lumbosacral plexus. The plexus that is made up of all the nerve fibers from the lumbar and the sacral region, moving to the pudendal nerves, obturator nerves, and at below the knee, the nerves give further branches and changes into the common peroneal nerve and tibial nerve and deep peroneal nerve. Peroneal nerve basically have types: superficial, deep, and common peroneal nerve. Three types. Okay, and basically the foot drop, that is the symptoms of the loss of the dorsiflexion of the foot, and unable to move or unable to walk properly, the gait impairment, that is basically due to the damage in the common peroneal nerve. The posterior view, in the posterior view, basically the sciatic nerves appears at the posterior of the thigh and causes the pain. That is the sciatica usually runs or usually excites from the posterior of the thigh or posterior of the hip due to any of the impingement that can be throughout his path. Into at the point of the knee, turns into tibial nerve and gives the branches of the common peroneal nerve, as you can crosses the fibular head, which give further two branches, the tibial nerve branch and the sural nerve branch, same as in the anterior part and the posterior part, the sural nerve. Now moving on to the case study. Basically, the case was about the nerve conduction test report which I have received about the right tibial sensory and left tibial sensory and motor examination. After the study, we have concluded and result that the right lower limbs nerve showed delayed latency. Delayed latency means they shows the delay supply. And moving on to the low amplitude at the side of the lumbar spine nerve compression and disc bulge L4 L5 lumbosacral spine. What basically the conclusion says is there is a delay. There is not a normal response or normal supply or normal impulse that is transferring from the lumbosacral region to the lower limbs and indicating a disc bulge at L4 L5 levels. So according to this, what can be the motor study examination reveals and what sensory study examination reveals includes, there are many points which says there are the weakness in the lower limb, there is the weakness in the foot, there is a involvement of the sural nerve, there is involvement of the peroneal nerve. So here again a question arises: is there any link or any sort of complications in the disc bulge L4 or L5 level that may lead or shows the symptoms of the lower limb or foreleg, hypermobility at the ankle, dorsiflexion, symptoms of like foot drop? So, yes, it is definitely possible, because the root and the cause and the basic trunk of the basic plexus that is involved are all the same. So, the symptoms or any of the compression throughout its part may lead to the foot drop. It is not necessary that any of the damage or any of the compression at the peroneal nerve, near the knee or near the fibular head, or any of the lower limb deformity leads to the symptoms or signs of the foot drop. It can be the cause at the back or at the root value, that is the disc or lumbosacral plexus. So, how it does happen and why it happens? So, considering the neuroanatomical explanation of all the scenario, you might have get some of the response or some of the background image of what is going through or what is happening. The L4 L5 nerve roots contribute to the deep peroneal nerve, okay, and which innervates the tibialis anterior, the primary muscle for the ankle dorsiflexion. There are certain muscles which we can name as that prime movers, or which are synergy. They allow the assessments, and some are fixators. Throughout the movement they allow the fixation. The movers, or the main muscles that supplies the dorsiflexion, or that supplies this movement of the foot, is the tibialis anterior, which is basically supplied by the peroneal nerve. एंड प्रोनियल फिब्युलर नर्व बैकग्राउंड इसकी अगर हम देखें तो L4 L5 nerve root is contributed. So any of the disc bulge at L4 L5 level may cause a compression of the main root and following to the weakness in the lower limb and foot. L5 radiculopathy can result in the weakness in ankle dorsiflexion, difficulty in the foot liftings, sign or symptoms of the foot drop, similar thing, sensory changes over the dorsum of the foot, and gait abnormality. So, how these patient appears? These patient appears with the gait abnormalities, basically the steppage gait, the type of the gait in which we lift or step, just like to uh, climb the stairs. This type of the walk they usually shows because of their lack of dorsiflexion. L4 L5 nerve root that can be possibly involved if L5 motor deficit, dorsiflexion weak हो जाती है, foot drop, muscle weakness. Key muscles that are involved are the tibialis anterior, extensor, hallucis longus. Sensory area that might get affected is lateral leg and dorsum of the foot. So, if the cause in the back, if the cause is in the disc bulge, or if the cause of the foot drop is in the root, what can be the possible diagnosis which can be involved? It can be a slump test, or it can be a straight leg test. Okay, straight leg raise test. So, performing this, you can easily diagnose which is the root cause of this problem. Differential diagnosis that can rule out includes the peripheral neuropathy. You might compare the sciatica with this condition, or so if the patient is not lifting the leg properly or foot properly due to the sciatic pain, you might get confused that the symptoms can be the same, and you can confuse and you can differentially diagnose it as the sciatic pain or weakness or pain, motor neuron disease or stroke or upper neuron lesion, any of types spastic signs seen in the leg. Usually the legs appears very heavy and you lift it or perform the SLR, or even you perform the glides of the sciatic nerves, you feel very tough or very hard or spastic. So you might get confused with the spasticity condition. So what can you do being a physiotherapist? Physiotherapy basically play a vital role in conservative management of various things. You are not someone that non-conservatively treat the patient. Conservation is all what we meant and what we do. So basically, L4, L5 disc bulge causing the L5 radiculopathy, and if there is not radiculopathy, just a motor loss at the lower limb, so relieve the nerve compression symptoms. We restore the ankle dorsiflexion. We prevent the muscle atrophy or joint contractions. Improve the gait and function. So how we can do it? How we can all manage all our things, and how we can particularly make a treatment protocol for a patient, and what are the exercises and what we have to do and what we not to do and what we should avoid to improve the condition includes the following things. Acute phase management, basically control the pain and inflammation. There can be a pain or there cannot be a pain, there can be inflammation, there cannot be inflammation. It is not necessary with the weakness or with the dorsiflexion of the foot drop that you are facing the pain. Patient with the foot drop usually complains of no pain, but if the patient is with the sciatic nerve involved, or with the root cause that is involved, L4 L5, yeah, L5 nerve root, then there might be a possibility of pain with the SLR. So how can you conservatively treat the pain inflammation? By the rest and aggravating activities. Rest from the aggravating activities, prolonged sitting, any of the static posture. Avoid the patient to sit for long, avoid the patient to lie for long, avoid the patient to stand for long. So basically, avoid the patient for static postures. Next, we can do McKenzie exercise. McKenzie exercise protocol, we will have another video on it. It is basically a very authentic and top class exercise protocol which can be used for extensive bias conditions, and we can treat them properly, especially if the symptoms are centralized, means the root cause. So we should add on the McKenzie exercises for the trunk stability, for the core muscle strengthening, and for exercises. Then neural glide of L5 level. Neural glides basically, manual therapy involves mobilization involves the soft tissue mobilization, joint mobilization, periphery and central joint mobilization, involves the nerve glides, all of the things. So moving to the nerve glides is the best option. It just tense the nerve and release the nerve, the basic principle behind the nerve glides. And sciatic nerve glides can be through the SLR, and with adding on the dorsiflexion, and can be due to, along with the slump test. Electrical muscle stimulator can also be used simply. Subacute phase or mobility or strength focus. The basic goals of subacute phase includes the mobility and strength. So in subacute phase, what will we add on? We will add on the McKenzie extension exercises, pelvic control and core stabilization exercises, neurodynamics. Neurodynamics includes the sliders, tensors, or we can move on to the active assisted exercises, active and then resisted exercises. Basically, we will perform the isometrics. Isometrics will be promoting the recovery as soon as possible. So basically, we will start with the isometrics. Isometrics, moving from the active assisted to active and then resisted exercises. Basically, focusing on the tibialis anterior, extensor hallucis longus, and peroneal muscles. Chronic phase basically is the recovery phase, which includes the gait and function of mobility, which basically involves the gait and function, improvement of the gait, improvement of the function by strengthening and by gait training. Gait training basically involves simple walk and ankle foot orthosis. These are the orthotic measurements or orthotic protocols that can be taken and given to the patient. Practical heel walking, correct steppage gait, strengthening of the closed and open chain exercises for limb and core strengthening and posture correction and balance proprioception by using the wobble boards and single leg stance. These are some exercises for the strengthening of the lower leg.